chair.
No.
You want me to start? You want me to start? Can I make a start? The gentleman, the moderator, you need to introduce us.
Yeah, okay. Yeah, I have the micro.
We've got a mouthpiece. Do I need to speak in this? I need to use the microphone, right? I need to use the microphone. Okay. Right. Start.
So thank you for joining to this interesting session to talk about a hot topic to the treatment of the common femoral artery, endovascular, open surgery, hybrid, and we'll see. It's my pleasure to introduce the first speaker, Ahmed Nasef, who defend the open surgery.
Thank you, Mr. Chairman. So I've got 15 minutes, right?
Yes.
Well, let's try and make it shorter than that even, and then make for a discussion. For a discussion. So what I've been asked to talk about is to defend the position of surgery in common femoral artery lesions. The idea is that most of the arterial tree is now amenable to endovascular procedures, and why is the common femoral artery still resistant? I have no disclosure, but I have an acknowledgement as Professor Al-Awaini contributed with slides and ideas. The common femoral artery occupies a unique position in peripheral vascular disease management. You expose the common femoral artery and you endovascularly treat the arteries proximally as well as distally, or you expose it and treat it itself. It's only recently that the common femoral artery has started to lend itself to endovascular management. Endovascular therapy, however, is increasingly performed due to perceived lower invasiveness and shorter hospitalization. And the question is whether common femoral endarterectomy still have a role or not. This is the anatomical classification of common femoral artery disease, and you can see that type 1 and type 3, the most extensive types, with type 1 extending proximal to the inguinal ligament and type 3 involving and straddling the common femoral artery bifurcation. Both of them combined make up for 70% of common femoral artery lesions. What do the guidelines say? Well, the guidelines suggest that in significant common femoral artery disease, particularly when the profunda femoris artery is involved, open surgery in the form of endarterectomy should be offered. They don't say should, they use the word reasonable to offer, particularly if endovascular approaches adversely affect the profunda femoris artery pathway. So if we feel that the stent or the angioplasty or whichever plaque modulating intervention we're going to use, be it shockwave or otherwise, is going to compromise the profunda femoris artery, what they are essentially saying is that it is better to resort to endarterectomy. They also say that for the young and fit, because of the higher patency rate, open surgery is better, whether you feel that the profunda femoris artery will be compromised or not. There are special anatomical characteristics that are really peculiar to the common femoral artery and that make the common femoral artery a vessel better treated by open surgery. It has a strategic location with a bifurcation that you need to worry about. You do have to pay attention to the profunda femoris artery, whether by way of protection or by way of clearing and performing profundoplasty at the same time. Lesions in the common femoral artery tend to be coral reef like. You open the femoral and there is a posterior plaque mushrooming from the posterior wall or straddling onto the profunda. It's a vessel in a hip mobility zones, and there will be concerns regarding stent fracture and mechanical stress if this is the approach that's been taken. It's a superficial artery, so many would say, well, you could do an endarterectomy and profundoplasty under local anesthetic. I do not entirely agree with this because profundoplasty can sometimes be quite extensive, requiring dissecting down to the second and the third order branches, which might not be easy in the context of a local anesthetic. In any case, it is a superficial artery, and some perform these procedures under local anesthetic in high-risk patients. And then there's been several high-quality comparative studies comparing endovascular therapy with common femoral endarterectomy. Most significant of which is the cauliflower study, which reported in 2022. This is the largest multi-center comparative study to this day. They included more than 1,000 patients from 66 centers, and they randomized them between endovascular therapy and endarterectomy. And you could see the Kaplan-Meier curve demonstrating higher patency for endarterectomy over endovascular therapy, and the difference has been proven to be significant. So the significance value is at the bottom of the curve here, showing results that are more in favor of open surgery. If you look further into the study, there are several other critical factors that favor open surgery, although they might not amount to significance, like, for example, residual stenosis. The study revealed significant difference in angiographic results, and we are talking completion angiography at the end of the procedure, with 39.3% of those undergoing endovascular therapy left with 25 to 50% residual stenosis as compared to 1.4% of the open surgery arm. And this incomplete revascularization with endovascular techniques is logically something that could impact on long-term outcomes. Restenosis, because we've just talked about nodular calcification, and the coral reef-like calcifications cannot be adequately addressed by balloon angioplasty. We are going to talk about shockwave lithotripsy and so on, and I'm sure my colleague will address that, but in the absence of this sort of vessel preparation, it's understandable that a stent will fare less well than endarterectomy. There are stent-related concerns, and this might be old because the cauliflower study randomized, I think, up to 2021. So we're talking about technology that is off the past to some extent. But there are some stent-related concerns like fracture, in-stent stenosis, jailing of the profunda femoris artery. If the stent occludes, it makes re-intervention a lot more difficult, and we've mentioned the anatomical complexity in terms of being in a hip flexion zone. So all of these concerns would favor open surgery over stenting. The safety profile, I think it's understandable that perioperative complications and mortality are more in favor of endovascular procedures, but it is a balance. You are weighing those risks against residual stenosis and long-term patency. Patient selection what did the study show in terms of patient selection? The only group that has been shown to benefit from endovascular therapy of the common femoral artery are those non-ambulatory patients in whom there was no significant difference in patency and open surgery was a challenge. Primary patency, we've already touched on that with the cauliflower study, but this is another. The Bofi et al., when they reported in 2021, it's a meta-analysis that shows that in terms of primary patency and restenosis, open surgery fares better. Open surgery has a very good safety profile, and in terms of technique, it's a technique that requires particular expertise, but it can be acquired. And cost effectiveness, well, the cost of surgery is offset by that of re-interventions that comes with endovascular therapy. So in summary, why open surgery is superior? Open surgery is superior because of its better primary patency, because of complete recanalization and less residual stenosis, because of durability and less re-intervention rates. There are future directions, of course, in terms of endovascular therapy that my colleague will touch upon, and therefore I better leave that for now. I think for the benefit of my talk, there isn't particularly strong evidence in support of these novel techniques. They're not particularly novel now. We're talking 4 or 5 years. In conclusion, open common femoral artery endarterectomy and profundoplasty, with or without profundoplasty, should remain the gold standard for common femoral artery disease, and that the short-term advantages of endovascular therapy do not justify the long-term failures, particularly in those fit patients, but selection is critical. Thank you.